Hello, a warm welcome to the webinar, Reducing Social Isolation and Loneliness, the Impact of the COVID-19 Pandemic. The COVID-19 pandemic is finally over, but discussions, analysis of its effects for people and the wider society has all but stopped. And today we will focus on the social implications in the Nordic countries, more specifically on social isolation and loneliness. We are looking forward to an hour and a half of interesting new knowledge and discussion. And we are also happy to launch and present two brand new publications. And you can find them on our website, nordicwelfare.org. And my colleague Jenny will also add links to the reports in the chat. My name is Kaisa Kepsu, and I'm a senior advisor at the Nordic Welfare Centre in Helsinki, and I am your moderator today. I have also had the pleasure to be involved in this project for the last year and a half. And now I would like to present the next speaker, my colleague Kai Koivumäki, another KK. He is Deputy Director at the Nordic Welfare Centre, and we have been working together with this project. And while Kai is waiting to say what some opening words, we could glance at our program for today. If you can share the slide. Thanks, Saga. So in the first block, we will hear some research results about social isolation and loneliness during the pandemic in the Nordic countries. And in the second half, we will hear some examples on promising practice on how social isolation and loneliness has been combated in the Nordic countries. And lastly, we will hear a final commentary and have a short discussion at the end. And if we have time in the time slots between, we can ask questions, and perhaps some of yours will be raised to the speakers. But for now, Kai, the floor is yours.
Thank you so much, Kaisa. I'm really happy to welcome you all here on behalf of Nordic Welfare Centre. We are the organizers today and have been running the project that Kaisa mentioned here. It's always very nice to have this kind of final webinars, because it's a culmination of hard work that we have been doing, and we hope to share the results with you today. When the pandemic started in the beginning of 2020, nobody really know what it will bring with it. There were a lot of physical restrictions implemented in the countries, in the Nordic countries as well as in the whole world, and nobody really knew what it means to the individual citizens. And within the Nordic cooperation, also the question was raised: could we learn something from the other Nordic countries now today with the specific topic social isolation and loneliness? It was the Danish Ministry of Social Affairs that made the initiative originally. And then the Nordic Council of Ministers gave Nordic Welfare Centre an assignment, which then resulted in this project for the recent 2 years. Kaisa Kepsu has been the project manager here. But Nordic Welfare Centre, we are a knowledge institution, but we are not a research institution. That's why we often get some help. We collaborate with the external experts, for example, researchers. This is the case also now. We have found some excellent writers, Maria Arntzen, who will be presenting her report, and then also Mikaela von Kügelgen, who has written the other reports. Maria's report is a research review, and Michaela's is more a collection of examples, practical examples of good solutions to fight against social isolation and loneliness. Because well, what it means to be a platform in the Nordic cooperation, it is also very often to have really good networks, for example, different experts from the countries representing the actual topic. That's why we also have been we're really happy to have had this reference group. Can I get the next slide, please? This is the reference group, the expert group that has been contributing all the time during this process, and I just want to mention all of you and really thank you for this cooperation. Maria Ansen you will hear soon, as well as Lena Dahlberg. We have had Haldor S. Gudmundsson from the University of Iceland with us. We have had Thomas Hansen from Norway, Anu Jansson from Finland, Karin Lennartsson from the Karolinska Institutet, Sweden, Fredrika Nyqvist from Åbo Academy University in Finland, Christine Svane from Denmark. So big thank to you once again. I really wish that this webinar will give you some inspiration for good fruitful discussions in the future. Please use our reports, and also this webinar will be put in the YouTube afterwards, so you can recommend it hopefully to your friends and colleagues and networks. I think that was all from me, and I really wish you a good seminar today. Thank you very much.
Thank you, Kai. Now it's time for us to hear some of these research results we've been talking about, and I will give the floor to Maria Artsen. She's research professor at NOVA, a social research institute at the Oslo Met University. And Maria is the main author of this research review that is being launched today. And together with research assistant Franziska Rothe, they have done a huge job in putting together this new publication. Maria, please, we are eager to hear what you have to say.
Yes, so my colleague Franziska and I wrote this report. Actually, we did a review of the literature or all the research studies that were done in the Nordic country, and try to summarize what was found there. So there's not much my own work, but at least it's a summary of what has been done by researchers in the Nordic countries. And to be very honest, to me, it feels as if the whole COVID thing with the social distancing and the lockdowns feels already as something far distant, like a bad dream almost. But well, it was there certainly. And it started all in January. Well, you all know, but just to refresh our memories, when the first cases were detected in Sweden and Finland, and then shortly thereafter, the WHO declared it a global health crisis. And then there were actually 3 waves of well, steep increases, also periods of lockdowns and social isolations and face masks and all these horrible things. The first from March to July, and then they lifted all the regulations. Then again in November until June, basically to 2021, and then again from 21 October to April 2022. And I think it's now sort of quiet. I think not many people will expect a new wave coming, but the WHO is still sort of concerned that it could be start again. And then for the Nordic countries, well, the total number of cases was more than 8 million, and then well, 0.38% died, which is still a respectful, impressive number, 31,000 in all Nordic countries. And at the highest absolute number, which is the total number, was in Denmark and Sweden, and the relative number, so if we take the percentage only, then also smaller countries had high percentages, and especially Iceland, which was, I think, in the beginning of the pandemic, as used as an example or of how well it was organized. But then there was a steep increase also in Iceland in the third wave. So they end up quite high if it comes to the percentage of people getting COVID. So the ministers were interested, especially in the social consequences of this in this particular report, and we got more or less 4 questions from them, and then or maybe not from them, but in collaboration with the Nordic Welfare Centre, we developed these 4 questions. And with the first was, what is the impact of the pandemic among different groups? And then specifically on loneliness and social isolation. And the second question was, which group were particularly susceptible to loneliness? And then can we maybe see some typical mechanism through which COVID measures affected loneliness and social isolation? And finally, can we say something about differences between the 6 Nordic countries? And if so, how? So we did a literature review of, recent studies. Of course, there are not very old studies here because COVID is new. But so we did a literature review, and all studies that were developed in one of the Nordic countries were included. We included also studies with, basically the entire population except for children, refugees, and immigrants, because they were part of other projects. And then we took studies that focused on the current pandemic, on experiences of loneliness and social isolation should be mentioned, of course, and then the participants should live in one of the Nordic countries. Very briefly, for those who are interested to know this, that we found originally 436 studies, and in the end we kept 45 studies that we describe in more detail in the report, also to answer the 4 questions. Maybe good to mention that, sort of a disclaimer maybe, because none of the studies were developed to answer our 4 questions. So it's always a little, so sometimes we have to take a little detour to get there. And none of the studies was, for example, developed to compare the Nordic countries. And also most of the studies were based on the first wave. So we know quite a lot about the first wave. We know not that much about the second wave, and certainly not the third wave. When we started the study, maybe the studies were not yet published because it takes time to get it published. Another problem was that most studies were cross-sectional, which means only one moment in time. And then we cannot say anything about changes, of course, because then we need at least 2 time points. And also some people have high risk of not being included. For example, oldest old people who, we miss in interviews, because most of the interviews were online, of course, I would say, because of the social distancing. And so these people were missed, and also other people who were most isolated. They're most likely underrepresented. So it's not a very good it's a good representation, but some people are missed. And then the perfect study would then include all countries and then have representative samples and then follow people over time, but these studies actually hardly exist. So before moving on in this whole report, it were 2 things that we were focusing on. One is the loneliness, the other the isolation, and they are related, but not the same. I think it's important to keep that in mind. So loneliness here is defined as a negative feeling in particular. So it's a subjective thing. It occurs when the number of existing relations is smaller than considered desirable, as well as a situation where intimacy or quality one wishes for has not been realized. Where social isolation, on the other hand, is more like an objective state of being alone, marked by few or infrequent social contacts, which is then the outcome of processes and regulations in society. So because of what the government told us that we shouldn't have contact, that is something that was outside it was not a free choice, it's something that happened to us. Well, in contrast of these 2, maybe it's good to mention also that the being alone is also a sort of objective situation where people have little contact, but it's not it's not a sufficient condition for social isolation. And if we talk about social isolation, we think about what is done to us as a consequence of regulation. And also being alone can be something positive. People want to be alone, for example, in solitude. It's also not a necessary condition for loneliness, because people can also feel lonely in the middle of the crowd. Okay, so now I stop teaching. Now I stop talking a bit more about the 4 questions we had. The first was, what was the impact of the pandemic on loneliness and social isolation? Well, first we see actually in all countries that there was a substantial and sudden drop in the personal context with and between families, friends, colleagues, neighbors, students, healthcare professionals in all parts of society. So there was unmistakably an increased social isolation across all social groups. But we also saw that the increase in loneliness was actually relatively mild during the first wave, and mainly in people who were relatively healthy. But then the longer the pandemic lasted, you see, okay, the second and the third wave, then well, maybe people were sick of it or something and didn't like it anymore. So some people became much lonelier than others, than other people when socially isolated. That was also an interesting finding. So the impact of isolation is not equal across all the groups. That is what we found out for this one. And then for the second questions, we found that the question was who in particular was susceptible or hard hit by the social isolation. And then I think we found that social distancing measures basically isolated all citizens, but those that became most lonely were, well, women as compared to men, also the youngest people in our studies, and the oldest, 85 plus. Those who were living alone were more hit than those who lived with others. Also people with lower education, unemployed people, and people with mental illnesses or disabilities. Those were the people who were much more lonely during the pandemic, during the times of isolation, as compared to their, other people who did not have this condition, so to say. And then, okay, how then was there a link between this social isolation and loneliness, or why did loneliness increase in some people? Well, one obvious reason maybe is that these social distancing measures actually hindered people to be physically close and then provide instrumental support, which then of course leads to a deficiency in the support. So people really were in need of support, but they didn't get it. And then that is unmistakably also related to loneliness. Another typical finding in a couple of studies was that people felt insecure about, well, the virus, especially in the beginning. We didn't know how lethal it was, how deadly it was, or when you would be hit or something like that, especially before the vaccines came out. And there was a risk of dying, and that was really emotional distressing, and therefore raised loneliness. Another sort of surprising finding maybe was that some studies found that people said, well, the communication actually about hospitals or the nursing homes was very inconsistent. Then we could do this and then we could do that, and that was really annoying, and also raised our feelings of loneliness there. And then there were a couple of studies focusing on social media use. Of course, that is a sort of hope that can we use social media instead of meeting each other in person. Yes, it can indeed lower loneliness, and that was also found in a couple of studies, but also studies found that it actually led to an increase of loneliness if especially people compare themselves to those who are doing better. And this is what psychologists tend to call upward comparison. If you look at the pictures of these happy people and you don't have these kind of pictures, or you don't have these nice stories, then you can even feel worse than without knowing all this. But as maybe I told that in the beginning, the loneliness increase was not very, very remarkable. And the question then, of course, is, okay, why was it lower than expected for some? And one thing we found was that, okay, there is what we call destigmatization and social comparison. So people felt that they were no longer stigmatized for being lonely. This is especially for older people. I myself am a researcher on older people, and it's very often seen that people who are older people don't dare to say or admit that they feel lonely because it's sort of not well, it's stigmatized. But actually the stigma went away. And also this downward comparison. So there were always people who have it worse than we. So that could be a reason for. I think also the raising the awareness of who was at risk in media, newspapers, and so on have also prompted people to stay in contact with those at risk. And also these public actions that has been to encourage, for example, healthcare professionals, boost well-being and reduce loneliness. So sort of we're all in this together feeling. And then even for some mentioned that it actually was a relief to have less social context. Well, we're all different people. And then the last question was, do the findings vary across the Nordic countries? Well, yes, when we look at the numbers, we see remarkable differences between the Nordic countries, also between number of cases, number of deaths, admissions to the intensive care units, and also the timing of regulation differed with Sweden, I think, as an example of more liberal in the beginning during the first wave. But well, we didn't have the right studies actually to come to very strong conclusions in this sense. So maybe that's a sort of disappointing finding. But anyway, I mean, I think we should be very careful not to overstate or not to jump to conclusions that we cannot support with data. So we ended the report with some recommendations. The first was maybe policymakers should devise strategies if there ever comes a similar situation, devise strategies that are effective for the right groups at the right time. It's very important to realize that one size does not fit all. I mean, the older adult doesn't exist. We have large variations, but it also counts for other age cohorts, I would say. Also, future interventions should include targeted strategies for younger adults and people with mental illness to decrease the risk of long-term health consequences, because also after the pandemic, there's still some negative effects on health. Solutions should be worked out for those who became unemployed. That was one study who came with that. And then the psychosocial well-being of people with disabilities should receive special attention. And also ensure a greater inclusion in society after the pandemic. And then for health and social care practice, we would recommend that adolescents and young adults with cancer should receive extra support and attention. They, in some studies, mentioned that they felt sort of ignored during the pandemic. We should also be aware of special needs of mothers with complications during pregnancy. There were a couple of studies focusing on that. Attention needed to caregivers of demented spouses who are still living at home, which they also form a specific group of people because professionals didn't get to the houses anymore, and then the caregivers felt really very left alone. And then being trustworthy by being thorough and consistent in the provision of information and complying with the rules. And then maybe they should invest more in online services, but there's some, well, it's not very straightforward maybe, but at least educate people in the use of it. And then I have a last one and then I stop. The take-home message, I think, was that the more people depend on others, the greater the impact of social isolation, and therefore the greater the feeling of loneliness. So the following groups should be followed carefully, we think. When social distances is announced, it's the oldest old, people with disabilities, and people in emotional distressing times. For example, teenagers, for example, pregnant women, people with life-threatening illnesses. And then if social isolation cannot be avoided, it's important to communicate consistently and comply with regulations, as this will increase trust in institutions and reduce loneliness. That was it. Thank you.
Thank you, Maria. So much, very interesting. And I will give the floor right away to Lena Dahlberg, Associate Professor in social work from Dalarna University in Sweden. And Lena is also a senior researcher at the Aging Research Center at Karolinska Institutet and Stockholm University. And Lena will give a short commentary on this research report. Please, Lena, the floor is yours.
Thank you, Kajsa, and thank you for inviting me to be part of this seminar. First, I would like to congratulate Maria and Franziska on a very nice report. I think it's comprehensive. At the same time, it's accessible, and I think easy to read also for people who may not be reading research reports every day of their lives. And I think the value of a review cannot be underestimated. You can read the findings of one study and you find, for example, positive results, but to use that as an evidence base for policy or intervention would be very shaky, since the next 10 studies may generate completely different results. So to get an overview of research is really valuable, and I think it's difficult and beyond what can be expected by policymakers or practitioners to do this. And I think as a researcher, I also really appreciate this kind of review. So I'll make a comment on a few aspects of the reports or this report, and I will start with age and risk factors. So in previous research, we know that the prevalence of loneliness takes the form of sort of a U-shaped curve from younger people via middle age, which is lower prevalence, and higher prevalence in older people, particularly the oldest old, like 75, 80 years and older. During the pandemic, this report and also European research have shown quite high levels of loneliness in younger people, but also the oldest old. But what's interesting in this report is that it shows that older adults remained lonely for a longer time. So for some older adults, loneliness remained at a higher level even after the regulations related to the pandemic were lifted. And by comparison, there was a much quicker recovery among younger people. The risk factors for loneliness identified in this report, so during the pandemic, were generally the same as we have seen as risk factors before the pandemic. Recovery from loneliness, however, is less researched than the onset or increase in loneliness. So we know much more about risk factors of loneliness than about factors that facilitate a decrease in recovery. And these factors are not necessarily mirror images of one another. So I think there's more work to do there for us researchers. In the report, several sort of explanations or mechanisms contributing to these changes in loneliness are suggested, and I thought I'll comment on a couple of them. The first one is that loneliness, as Maya says, relates to a personal standard where you evaluate your existing relationship in relation to what level or depth of the relationship you would like to have. And it is possible that these personal standards were lower during the pandemic, and this may compensate for the lack or loss of social contacts. And this would explain why the increase in social isolation did not always lead to an increase in loneliness. But so from a research point of view, I think this means that the association between loneliness and social isolation became weaker. And this is something that we are aiming to explore further based on Swedish data during the spring. The second explanation is around stigma. So loneliness is attached to a stigma, and during the pandemic there was a public discussion on loneliness, which may have decreased this stigma and reduced loneliness. But could it be that this decreased stigma actually makes it easier to admit loneliness, and that we instead would expect to find higher degrees of loneliness reported in research rather than lower degrees? I think another question to ask around stigma is what happens now. Does this change in how we view loneliness? Will it remain, or will loneliness again be stigmatized? A couple of comments on implications. The first one regards older people. So compared to other Nordic countries, Sweden had less regulations during the first wave of the pandemic, and we also had a smaller increase in loneliness, or hardly any increase at all in the first wave. But we, of course, had more spread of the virus instead. But we know from previous research that loneliness is also a risk factor of poor health. Today, we have a strong emphasis on aging in place, and we have had a lot of cut downs in care homes. So it is difficult to get a place in a care home, and research has shown that people moving into care homes are generally quite frail and at the last stages of life. So my question then is it right to isolate these people and protect them from the virus, or is it wrong to thereby deprive them from their social relations in the last part of life? Finally, I will make a remark on the methodology. As Maria presented in the disclaimer slide, there are limitations of the research that have been done during the pandemic, and the ones that Maria presented are very much in line with what I found when I did an overview of international research on loneliness among older adults during the pandemic. So the samples were not always representative. It was quite often convenience samples. Online recruitment was used a lot, which is problematic for inclusiveness. If you're not familiar with internet or doing things online, or you're frail, you're less likely to be included. And as Maria said, there's also a lot of research that were just cross-sectional with only one measurement point. And I think this shows the importance of long-standing studies that are repeated again and again, and that cover representative samples of the population, and that are collected, the data is collected in an inclusive way, and preferably with high response rates, so that also the oldest old and the frail are included. And based on that kind of research, we can draw more reliable conclusions on the living situation of both younger and older adults in the pandemic and in normal circumstances. Thank you.
Thank you, Lena. This all shows that it's not a simple issue to do this research at all at this point in time, and with the material that there is. You raised several good points, and I will give the floor actually to Maria. Perhaps you want to comment. Lena raised a few questions and had a few comments there for you. Do you want to respond,
Yes.
Maria?
Yes, certainly. Well, thank you, Lena. It was really, well, this is precisely how I know you. Very, very thorough and good research. Very, it's great to have you in the team. And also, there were a couple of studies I referred to, a couple of your studies I referred to or included. So great comments. Well, starting with the last one, I totally agree with you that it's how important it is to have longitudinal studies that we can use to answer also the other question about, is it right to age in place, or is it related to aging in place? Is it right or is it wrong? Well, I won't go into that, because I think it's more for ethics, for philosophers almost. It depends very much on your view to human beings, and I am more like the scientist that studies numbers and so on. So this is very hard to go into, but it's a very important question. And one thing I would like to say about that one is that both loneliness and social isolation are bad for health. Even if you don't become lonely, it's not good to be social isolated. We are human beings, that we need connections. There's a very interesting study in the UK that says that Steptoe is the main researcher that investigated the role of social isolation and loneliness with respect to mortality. And he actually found that social isolation is much worse for health than loneliness. So social isolation leads to an increase of mortality of 26%, whereas loneliness actually, if you take that already into account for loneliness, is not an additional effect. So aging in place, if that comes at the cost of social isolation, I think it's not good. Then we should go for a nursing home. And if it leads to loneliness, I mean, these things. So yeah, but let me just pick one other, because I think it's too many questions. But The other intriguing question I liked was, okay, did the stigma increase in maybe, or did loneliness maybe not just increase because we now talk so much about it? So people might find it easy to say, yeah, or to admit, yes, in fact, I'm also lonely. I don't know. I don't know the answer, but it's a good question. It's a good question.
Yeah, I also found that an intriguing question, because that's another way to put it. And also the question about recovery from loneliness, and that you touch upon also in your report a little bit, and you notice that some groups recover faster. Was it younger adults?
Yeah. That was also a finding that surprised me somehow. Surprised me. At least I didn't think of it. But for younger people, as soon as the regulations were lifted, they felt happy again, and they met with their peers, and it seemed that problems were over. But not so for older people. So it has a much more a lagging effect for older generations, and whether it has to do with resilience, to recover from emotional distressing periods. I think that's part of the reason that for older people it's you lose flexibility the older you get, so it might be there, but this is guessing. We would need to investigate this. So give us a new assignment.
There are more questions than when we started almost.
As always.
Yeah, well, thank you very much, Maria and Lena, and we will move on to the second part and look at solutions and practical examples and what has been done in the Nordic countries to reduce social isolation and loneliness. And it's my pleasure now to give over the floor to Mikaela von Kugelgen. She's a journalist, and she has approached this assignment in a journalistic way. Collected material and interviewed key persons for this report, and she did this last summer and fall. And now I will be pleased to hear more about your work, Mikaela.
Hej och välkommen också för min del till det här seminariet. Jag kommer att prata om de här praktiska och lovande exemplen från 5 olika nordiska länder, alltså från varje nordiskt land. Och först, vilka olika lovande exempel så valde jag tillsammans med gruppen. Så det fanns ett stort brett utbud av olika exempel, och vi försökte välja olika så att vi skulle belysa den här problematiken ur olika synvinklar på olika nivåer och på olika sätt hur man kunde tackla den här ofrivilliga ensamheten under coronapandemin. Och som sagt, ett exempel från varje nordiskt land. Och de här exemplen valdes med hjälp och stöd av NWC:s partnergrupper och de som är involverade i det här projektet, också de här experterna som är med här i webbinariet idag. Så att vi försökte få en så bred och mångsidig bild som möjligt från Norden och vad som gjordes faktiskt under pandemin. Och för att sammanfatta de här lovande exemplen, dels de som valdes men också sådana som jag har där i slutet av rapporten har jag nämnt kort några olika exempel som inte vi gick desto mer in på, men att som också visar på vad man har gjort i Norden under pandemin, så var att det var väldigt snabba lösningar, det var innovativa lösningar och innovativt tänkande. Och det fanns en väldigt så här stark och genuin vilja att faktiskt göra någonting för att minska på den här ensamheten och sociala isoleringen som blev som en följd efter att vi måste isolera oss och ta distans. Och det som ju såklart var en gemensam faktor för alla var att ingen hade tidigare erfarenhet av en sån situation som en pandemi, och det fanns inga färdiga lösningar att ta till. Så alla var på ett sätt hade samma utmaningar, att man måste verkligen agera snabbt utan att egentligen riktigt veta hur eller vad det kommer att leda till. Och just det här som jag redan sa, att liksom ingen nästan egentligen visste vad man ska göra, men att alla visste att någonting måste göras, speciellt när vi pratar om grupper som kanske inte är så digitalt bevandrade eller som inte har så stora sociala nätverk och som behövde hjälp och stöd för att helt enkelt inte bli totalt isolerade under pandemin. Det är då som sagt 5 olika lösningar som vi tar upp i den här rapporten, eller som jag tar upp i den här rapporten. Och i Finland och Sverige och Norge så blev digitala verktyg, till exempel Zoom-möten, så här som vi nu sitter i ett Zoom-möte, så blev en viktig del av det här sättet att försöka nå människor också under pandemin och den här isoleringen. I Danmark startades en telefonhjälplinje för personer med autism. Och i Island, så i staden Akureyri i norra Island, så börjar man röja snö för att folk ska kunna ta sig utomhus och röra på sig. Och nu kommer jag att titta lite närmare på de här exemplen från Finland, Danmark och Island, och så får vi höra mer om exemplen från Sverige och Norge av experterna som jag har intervjuat. Eller först det här att gemensamt är att alla ville försöka hitta det bästa möjliga för att undvika ofrivillig ensamhet. Och en annan gemensam nämnare var att, som sagt, att försöka hitta de här lösningarna så snabbt som möjligt för att undvika den här isoleringen. Men då Finland, det här Circle of Friends, vänskapskretsar, ystäväpiiri som det heter på finska, så det är faktiskt ett initiativ som har hållit på redan väldigt länge, och det här var det exemplet som jag hade med här som är det mest forskade och har mest evidens bland de här olika exemplen. Och det här vänkretsarna riktar sig till ensamma och främst då äldre vuxna personer, och grupper på 6 till 8 deltagare träffades under 12 veckor och en träff i veckan. Och förr, så innan pandemin, så gjordes de här träffarna alltid att man träffades ansikte mot ansikte, men under coronapandemin så blev det online-träffar så här som på Zoom eller utomhus också, där man sen kunde hålla lite distans. Och det som är intressant är att de här träffarna, fastän det är bara en gång i veckan i 12 veckor, så har det haft väldigt långvariga effekter, för att många av de här grupperna som har träffats eller lärt känna varandra under den här vänkretsperioden på 12 veckor, så de har fortfarande kontakt efteråt, och också just många av dem som träffades under pandemin och bara kanske sågs online, så har sen också efter pandemin eller när restriktionerna lättades träffats ansikte mot ansikte för att verkligen få umgås med varandra. Och mer finns som sagt om alla de här exemplen i rapporten. Jag går dem ganska så här kort och koncist igenom här, så vi hinner med allt program idag. Och nästa exempel är Danmark, som startar en telefonstödlinje för personer med autism, och den riktar sig då till personer med autism, men också föräldrar och lärare till personer med autism som kanske kände oro eller behövde hjälp eller stöd för att handskas med den här situationen. Och tidigare så har man haft liknande telefonstödlinjer med frivilliga som har svarat i telefonen, men den här landsföreningen för autism, den här danska föreningen, så då under när pandemin kom igång, så ville de, istället för att det är frivilliga krafter, så ville de att det är proffs som svarar på de här samtalen för att verkligen kunna möta de här personerna som behöver hjälp på bästa möjliga sätt. Och det här Mehdi Ovliaye som jag har intervjuat, som jobbar för den här landsföreningen för autism, så han sa att när den här telefonlinjen sen stängdes ner i slutet av 2021, så var det många som önskade att den ska fortsatt, eftersom det hade blivit ett väldigt viktigt stöd och en ganska lätt sätt och en låg tröskel att söka hjälp och stöd under svåra tider och också kanske när det inte är svåra tider. Och så Islands exempel om att, vilket är mitt nästan favoritexempel för att det är kanske lite otippat, och det handlar då om att röja snö för att då när den här pandemin startade så kom det helt ett så här nationellt, inte nu påbud, men alltså man uppmanade isländare på nationell nivå att gå ut och röra på sig för att det är ett bra sätt att också slippa stress och sådär, eller motverka stress, och det visar också forskningen. Och i Akureyri, som då är en stad på 20 000 personer i norra Island, så där riktades ju det här då i princip åt alla som behövde gå ut. Och inspirationen för det här kom från Sverige, Karlskrona, där de 2013 började med någonting som kallas för genusplogning, som säkert många har hört om, alltså tanken om att istället för att först ploga bilvägar så plogar man till exempel trottoarer, så att människor med barnvagnar eller kanske hinder sitter, man rör sig med rullstol eller så då kommer man lättare fram, att det inte är den här biltrafiken som prioriteras. Och de här tankarna från Island var, eller när jag pratade med det där med the mayor, nu kommer jag inte på vad det heter på svenska, från Akureyri, så sa hon att det var liksom väldigt bra hälsofördelar för en ganska låg kostnad. De röjer ju oavsett snö, men under pandemin så eftersom de var tvungna att skippa en del program, så då blev istället en del pengar lediga så att man kunde lägga mer pengar på den här snöröjningen. Det här var mina exempel, och jag ska ännu säga kort om den här metodologin. Jag har då alltså använt mig av en sån här modell med olika frågor, till exempel där man går igenom att målgrupp och vad har det haft för inverkan och vad har det för ekonomisk effekt och så vidare, för att skapa en så mångsidig bild som möjligt av de här exemplen, trots att det inte kanske ännu fanns vetenskaplig evidens för alla. Men bra, det här var min del. Tack för mig.
Stort tack Mikaela, och jag tycker att det visar att även små saker kan ha en stor betydelse när man jobbar mot ensamhet och social isolering. Okay, next up we will move into looking into more detail into two of these promising examples. And first we will hear from Erik Børre Rasmussen. He's a researcher at Oslo Met University. He will tell us about some research and user experience from a simple communication device. Do such things exist? We want to know more. The floor is yours, Erik.
Okay, great to be here. Thank you very much for allowing me to come and present the results and insights from a project that I'm very proud of and that I was a research leader for. And the project is called Simple and Safe Point of Contact with Relatives, or in Norwegian, Enkel og trygg pårørendekontakt. And this was a pandemic response project. The idea behind the project was that communication technology could be used to alleviate social isolation and loneliness among nursing home residents who, due to visitation restrictions, would not be able to have their family and friends come over and say hi. And so in order to sort of prevent loneliness and isolation there, we would want to see if a digital device communication technology could help ensure social connection with the relatives. And the communication technology in question is a solution called KOMP, which is the screen that you see here. It's basically a big screen with one button. So there's only one thing that you can do, and that is turn it on and off. And when it's turned on, you can see pictures that have been sent to it. You can see, and the pictures go into a picture carousel. So if there are 10 pictures in the carousel, you see one and then the other, and then goes around like that. And you can see messages that have been sent to you from people, and you can also receive a video call. So the trick is that when Comp is on, family and friends who are connected to the screen via an app on their smartphone or tablet or whatever, and they can send pictures that they want to send. They can send messages like "I'm coming tomorrow" or "Please remember your medications," and they can also start a video call. And the thing is that when the comp is turned on, you can just make the call, and then it answers it goes through automatically after a 10-second countdown. So it goes 10, 9, 8, and then the call is started. So if you don't want to talk to people who are calling, you need to actually turn it off. And there are many things to say about the design and the implications of the simplicity, which is complex on its own in a sense. But for now, given the 10 minutes that I have or had, we're going to focus on the fact that this is a technology that is designed specifically for users who are likely to struggle with what I consider conventional technologies such as tablets or smartphones, either because they're not used to them or because their fingers don't circulate blood well enough so that the touch screen doesn't respond, whatever. So if you are a 90-year-old pensioner who really knows how to use a smartphone, then this is not for you. This is for the ones that will struggle using those types of technologies. And Comp has been designed and created by a Norwegian company called No Isolation. And they were one of the partners in this project, together with Oslo Nursing Home Agency, which is the agency that is sort of responsible for the 19 municipal homes that were part of the project, where we implemented and tested Comp. So our question was basically, can Comp facilitate simple and safe points of contact with relatives? And what other effects might arise from using it? What happens when you put this technology in a nursing home? And so just very almost irresponsibly brief about the methods, because I'm a researcher, so I have to include it. We based our findings on a survey. So we did a survey at 3 different points in time. So at the baseline before they got the Comp, and after about 2 months, and then after about 6 months. And at each point of measurement, we asked for the perspectives of the elderly user and the relatives and the staff. So we have 3 perspectives on 3 points in time. I won't go into that too much in the presentation, but I brag. We also have interviews with nursing home staff and with relatives, and we also have objective user data from the data stream. So we know not what pictures are being sent. We can't see the content, but we know the number of pictures. We know the number of messages being sent, and we know the number of video calls. So we can say something about how often it's being used. Moving on then to the interesting bits. What do we learn from this project? What are the lessons? What did we find? I'm going to look at the survey results first, and then the interview results, and then try to sort of mesh it together. So the main survey results, they show that using Comp gives more and better social contact with relatives, which was what we hoped for. So I mean, that was a very positive thing. We saw that the majority of those who got Comp, they used it regularly, meaning once a week or more, and typically more. And among those who did use it regularly, we saw that they were more satisfied with their social contact after having used it. And we also saw that they did not have less phone contact or physical contact because of using Comp. So in other words, Comp did not suppress other forms of contact either. You just got more social contact, you were more socially connected, and you were happier with your social contact with your relatives. In addition to that, the survey shows an improved relationship between staff and residents. So we asked the staff to evaluate their relationship with individual Comp users. And in almost half the cases, they said that the relationship had improved because of the Comp. And in the other cases where it didn't improve, it didn't get worse either. So using Comp either doesn't change the relationship with the staff, or it makes it better. So taken together, you see that using Comp, or we find that using Comp, based on the survey, gives more and better social contact with relatives and with staff. Moving on to the interview results. The interviews do 2 things in this context. They support the findings from the survey, and they also go beyond it. So they support it by giving us a bunch of stories about positive user experiences in almost all the cases where it was used regularly. And I mean, so you get teary-eyed emotional stories, wonderful to listen to, about people who see their families again for the first time after a long time when they got the Comp, and also about people who are proud to show their great-grandchildren doing something or whatever. And it's very positive experiences, very cheerful. And I think it's interesting to note also, because I've been studying Comp in other contexts as well, that this is not uniquely tied to the pandemic. This is not just because there was a pandemic. People like to see their grandchildren. Also, the staff emphasized that using COMP did not suppress other forms of contact, as we saw from the survey. And importantly, I think they also stated, the relatives and the staff, that COMP gave better social contact off screen. So not just the connection that you get from the screen, but when you're in the room there with them, the pictures on the screen give you more stuff to talk about. And in contrast to the picture on the wall of the wedding photo that you talked about for a number of times, and you get tired from it. You can talk about stuff that's going on in the lives of the residents' family. In other words, people that they care about and stuff that they're interested in, and that makes for more immersive and interesting conversation, of course. In addition to that, the interviews, as I said, they go beyond the survey results. And first of all, they do this because we learned from the staff that they found COMP to be as easy or hard or easier than conventional alternative technologies to be used for this purpose. And that's important because it doesn't matter if COMP is super positive for the residents if it's hell for the staff. It has to work for both of them. And as we see, at least it's not worse, and for many, they found it to be easier. There were a few negative experiences, mainly people not interested in COMP. They didn't like what it did, they weren't that interested, and so they took it away. There were also a few cases of confusion and worry. People didn't understand what was going on the screen. Is my son here, or is he? What's going on? And either they then stopped using it because it wasn't for them, or they sort of were there with them, make them comfortable, or made some adjustments. For instance, telling the family not to send pictures of, for instance, a late husband, if that sort of always reignited feelings of loss and grief, stuff like that. And then it turned into positive experiences. And very interestingly, I think, COMP also worked well for residents with dementia. Now, a bunch of the nursing homes didn't think it would, so they didn't offer it to people with advanced stages of dementia. But the nursing homes where they did offer it found that it did work very well for many of them. And it was even included as part of dementia care. So they used it to alleviate stress. They used it to take attention away from stuff that was aggravating, that made them act out, for instance. And they also used it strategically in relationship with the relatives. So they would, for instance, plan to make a video call to talk about something that's perhaps frustrating or hard to accept. But together with the staff there and the relative on the COMP, they could make that sort of work, and so on. And even, I find this very interesting, COMP wasn't just used as a way of just showing pictures of family, but for some people who have forgotten that they have a family, you could use it to show things that are important to them from their life, so that they can connect with it either way. So in brief, in summary, using COMP in a nursing home context is a promising way to provide more and better social contact for residents on and off screen and with relatives and staff. COMP works for residents with dementia too, and can be and was integrated into forms of dementia care. And simple measures that you can read about in our report can increase the likelihood of successful use related to who you give it to, follow-up routines, and information. Sorry, I went a bit over time. This is our report. It's in Norwegian. We're writing stuff in English shortly. Seri Shakhtar was part of it. Thank you for listening, and sorry for talking fast.
Thank you, Erik. I can just add that you will all be sent this material if you want to take some more time to look at these. And I mean, Erik, really impressive and positive results, and impressive research as well. And I'm sure a lot of people have many questions, but I think we will have to move on and move on to Matthias Ehn, who is a PhD and researcher at Örebro University, and also active at the Swedish National Resource Centre for deaf blindness. So perhaps if we can get Matthias here on screen, and we can hear about interventions for people with deaf blindness.
So I hope I'm unmuted now. You can all hear me.
We can hear you very well, and
okay.
And we won't have to struggle with the PowerPoint this time.
No,
I'll just give the floor to you, Matthias.
Thank you. Since I like to be in focus myself, I skipped the PowerPoint presentation today. and I will talk a little about my field, which is deafblindness. And today I will not talk so much about my research, but I will talk a bit about clinical experience that I'd say was giving us some ideas for new research. And first of all, since my target group, people with deafblindness, is not so well known, I will just shortly start with the definition. And people with deafblindness is a very small group in society. To be identified as being deafblind, you have to have a combination of vision and hearing impairment, and it has to be severe to such a degree that the senses, the hearing and the vision, cannot compensate for each other. And since seeing and hearing are the most important senses for all communication and all remote communication, we face a lot of problems when we meet people with deafblindness. We have problems communicating face to face. We will have problems for people with deafblindness accessing information and to be able to move around freely. And this quite often also in everyday life outside COVID-19 will lead to problems in social connections with other people. So that's the case, and that is what we started with when COVID-19 arrived. So we have people who mainly are dependent on low vision or no vision at all, low hearing or no hearing at all, who are sign language users or tactile sign language users. That means that they use sign language in their hands. And from one day to another, we had a situation where all authorities told us that you had to keep distance to others. And how can you keep distance to others when you need proximity in all situations to be able to move around freely, to be able to access information and to communicate with others? That was something that I had in my office here in Stockholm at the counseling and support team for people with deafblindness to face together with all of my colleagues. We had a lot of problems, and it was so interesting listening to all the other presentations, because first of all, we didn't know for how long will this pandemic go on, and since our target group do not have you don't need hospital care, and many things that we do we could put on hold. So that's what we started doing, but quite fast we understood that this pandemic will continue for quite a long time, and for some people who are normally visits us in person, we really had a problem how to get connected to them. And we at the beginning had access to remote digital formats that we could access our clients, but they were not used to using them, and we were not used to use them either. And how can you learn someone how to use, if you're a low vision teacher, how can you teach someone how to use the white cane, for instance? You cannot do that remotely. You have to be there in person. If you want to study tactile sign language and how to learn signs, if you have no vision, you cannot do that with a video camera on. You have to do it hands-on. And if you hold someone's hand, it's difficult to keep the distance of 2 meters. And I think we were surprised to see that many of the formats that we thought were very inaccessible, using video cameras, using devices, that for some that we did not expect it was accessible, it turned out to be. Many people, we didn't close down our office, but many people didn't want to come to us because they were afraid of being infected in the taxi on their way here. So they choose to try to use the remote formats, and then the formats were normally accessible only in smartphones or tablets, which for some people were too small screens. So we developed gradually different kind of support systems that we could use it on a ordinary PC and so on. But also we started up having meetings outdoors. I don't know how many meetings we had outdoors. People trying to teach sign language out in a park close to the house of the resident coming to us. Or it could be going out walking with a white cane, of course, outdoor, and you could keep distance. But we really faced a lot of ethical problems, and that was sort of also something that people with deaf blindness met in all their everyday life. If you cannot hear very well, you are very dependent on lip reading, and if you have a face mask, you cannot see the lips of the one who's speaking. So we were prescribed to use such devices or visors, I don't know what it's called in English, but they always, it was a bit of glare and difficult to see, and we really had to balance the risk versus the benefits using that kind of devices, and we had very difficult to find sort of ideas from the authorities how to balance the risks versus what we thought could be beneficial for our clients. As a psychologist, I could see that many people withdraw from activities that they normally used to do. They didn't go to activities organized by the Association of the People of Deaf Blindness because they had to shut down due to regulations. And for many, the isolation that is quite common among people with deaf blindness became even worse. They were really socially isolated, and for those who didn't have a family or relatives close that they could see, I really could see that many people who normally would not go to see me digitally or in person, they came and they were really lonely. And we tried to convey hope. This is a period of life. It will go over, and hopefully things will open up again. And for some, I think these talks that we had was very good for them. What happened later on was that I could see among my colleagues a lot of really good ideas. One person, for instance, they used to teach Braille with people with deaf blindness, and normally they came here to our clinic, but they started with a correspondence course sending people things on Braille, and the format was not really perfect, but we had some way to keep up the contact and to contact everyone, and it was so important doing that. It was so interesting listening to Erik's presentation, because I think for many people the problem is not to take part in a digital meeting. That the most difficult thing is to access the formats. You have to sort of identify yourself with a bank ID. You have to go into very inaccessible formats where there are no standards for screen readers or magnifying programs that is quite oftenly used, or you cannot access them with your hearing aids, and so it could be difficult to access with a remote interpreter. So I think we did what we could, and I think that one client said to me one thing that I think was very interesting. We, as a person with deaf blindness, I'm very used to feel lonely. I'm very used to feel lonely among other people, and there are many situations where I cannot access the communication, and therefore I quite often stay at home and I don't withdraw from activities. And now when we have this COVID-19 situation, everyone in society will really feel how it feels to be so outside society, as this is the situation for me all the time in my life. And it was really, I think, I really got touched by that thing that person said, because I think there are so many things that we now design in our society to sort of increase the accessibility digitally for people with in society, and we have to really make sure that people with deafblindness or other kind of disabilities or older people also have the possibility to access them, because otherwise we will leave them behind, and the situation of being lonely will be stigmatized again. And I think that there are so many things that we can learn from this, and I think that people with deafblindness perhaps can teach us from the situation. And I have to stop there because I know my time is up.
Yeah, thank you, Matthias. And I'm sad that we needed a pandemic for us to understand at least try to understand more about what it's like to be outside many of the activities. So really important work, and thanks for that. And I'm sure we would have a lot of questions again, but we will move on and get a more of a public authority perspective next, and this time from Finland. So it's my pleasure now to invite Professor Mika Salminen, who is a virologist and currently director of the Finnish Institute for Health and Welfare, THL, in Finland. And he has been working for the prevention and control of infectious diseases in Europe and globally, and was in charge of official corona crisis information in Finland at the height of the pandemic. So a well-known face for us in Finland. Mika, welcome. Great to have you here, and it would be great to hear a general perspective from you for the corona period, and how was social aspects taken into account when decisions were made, and are there anything that you could say that could have been done differently? But I'll leave the floor to you, Mika, please.
So I'll just discuss a little bit about the way that the pandemic was handled. I'll just correct one thing. I'm not the director of the institute. I'm director of the Department of Public Health and Welfare, which is just one part. But during the pandemic, I was actually pretty much working 100% on pandemic measures. In my previous position, I was head of the Health Security Department, which was basically sort of the substance of the pandemic causing agent. Although today we actually discuss kind of the other effects of the pandemic, which is very good because it has not been discussed enough. And I'll try to give you some idea on what was considered, what was not, and what we could learn. And I think there's a lot of things we could and especially should learn from how the pandemic was handled. So this is a kind of a schematic of how the leadership worked in Finland for the pandemic management. And you may
Mika,
know.
Sorry, I'm sorry, but we can't see the pictures. Did you change it?
Okay, let's do it.
That's it. Yeah, thank you.
Yeah. There, this is the schematic of kind of the network of different actors and leadership during the crisis. And you may know that for twice during the pandemic period, we had special circumstances put in place in Finland, not quite undantagstillstånd, but close to that. That gave the national government much more powers than they usually have, and really the most important was that they could issue decrees which were immediately in force. Whereas normally, if you give a government decree, it has to go through normal scrutiny in Parliament and then only be adopted. In this special circumstances, the decrees were only sort of post-fact assessed, and that way it was kind of faster, but also gave the government more powers. We also changed much of legislation during the pandemic. In practice, much of the measures were developed by the Ministry of Social Affairs and Health, who had a very large responsibility for pandemic management. THL doesn't have any authority power, but we were the agency that dealt with both surveillance on how the pandemic evolves, and also develop a lot of the guidance that were sort of practical infection control guidance. And also we had to try to assess effects of various proposed measures that the government proposed. I personally sat in over 70 meetings of the full cabinet when they dealt with the pandemic issues. Maybe the message from this is that there were lots of actors, because of course the pandemic affected pretty much everybody and all sectors, and that meant that it was quite a challenge to manage. If we look at the sort of mitigation and control strategy that in practice was followed in Finland, and the interesting thing is that you will not find this mitigation and control strategy in any government decision or pre-pandemic plans. This is actually sort of our interpretation on what actually happened and how the strategy worked, although it's never been written exactly like this in any of the government documents. There are elements of this, but it's not quite this clearly put forward, and that's why we tried to formulate it sort of post factum. The one thing which is clear is that the overall strategic objectives of the COVID-19 response was to protect the health and lives of the people, and this comes from the Constitution, especially its 7th and 22nd paragraphs. And what is important to understand in the Finnish context is that the Chancellor of Justice, who is supposed to monitor and make sure that the government decisions are following the law, from the beginning of the pandemic took a very strict interpretation of these two statutes in the Constitution, that the absolute responsibility of the government in its decisions and its measures is to protect the health and lives of people, which was reflected in the quite strict way that the measures were conducted in Finland, for example, comparing to Sweden in the beginning, especially of the pandemic. Then later on, it wasn't that much of a difference. Secondary to this objective was that any measures should disrupt normal life only as much as is necessary and proportional. And these are actually absolute requirements by themselves in the legislative process. And a couple of times our constitutional committee of the parliament actually prevented some measures that they did not consider to be either necessary and especially proportional. And then the third principle was to be that to try to avoid collateral damage, but accept at the same time that some may occur. Now, the problem with the pandemic management was that, especially over time and as the pandemic went on, the first principle totally dominated in the decision making, so that very little sort of risk was acceptable to the politicians who had to make these decisions. There are of course many reasons for this, understandable reasons, and then some which maybe are not so they may be understandable but slightly less defensible. In the stages, we had a very early stage strategy where we went quite quickly to a precautionary principle that guided the heavy reliance on unprecedented and strong control measures to reduce social contacts. This was actually evidence-based because we had studies that could inform us about how much contacts there are, social contacts, physical contacts between people in different age groups and different population groups. This is actually EU-sponsored work that was done prior to the pandemic, and it really guided some of the measures that were taken in Finland in the early stages. Then after the very first spring and maybe the summer, there was kind of a phase where it was very unclear what would happen. There were vaccine development going on, but it was considered a slow process by most experts that wouldn't be able to address the immediate pandemic problems. But during this time, the strategy basically was to try to stall and to prevent a very widespread spreading of the virus and win some time. Then when it became obvious that the vaccines actually were developed very quickly and they looked very good and both effective and safe, then we went into, and this was the second year of the pandemic, into a vaccination scale-up strategy, because we couldn't vaccinate everybody immediately because there wasn't enough vaccine. So that was kind of the second phase of a stalling tactic, whereas as the vaccination coverage slowly increased, especially among the groups of the population that were at or had been determined to be at higher risk than others of serious disease or death. The restriction measures were kind of adapted to the immediate situation. There was very tight follow-up all the time on both the epidemic and the vaccination strategy. And then finally, when basically everybody had been vaccinated who wanted to be vaccinated, and the coverage was good, then vaccination protection, especially against serious disease and death, replaced the control measures. Now, this is a schematic of the pandemic in Finland with the strategic stages, and what you will see here, which is an interesting observation, is that honestly, if you look at the whole pandemic situation until the first really January in 2022, we had very little disease in Finland, and only when we actually relaxed the restriction measures did we have a significant spread and the biggest waves. This doesn't go into this year; it's only last year properly. So it's in a way ironic that the worst sort of epidemic situation from the point of view of widespread spread of the virus happened only when everybody was already vaccinated. On the other hand, that's exactly how it was also thought that would happen, especially when we learned that the vaccines do not prevent transmission, unfortunately. Now, the control measures, of course, even though the principle, and that is clearly stated in the first governmental principle decision, which was guiding the strategy in the beginning, was to avoid negative effects of the restrictions and the control measures as much as possible. There certainly was multiple negative effects, especially in the beginning of the pandemic. Many of the health and social services access to them diminished substantially. And this was mainly at that time really due to fear and anxiety among clients. So people didn't seek services because they were afraid to meet other people. There was also substantial personal transfers from child and maternity services and many social services to testing and to vaccination later, and to contact tracing and testing, which normally are very poorly resourced. There's not much going on in that part in normal times. And suddenly this was scaled up massively. Elective and non-urgent healthcare services were postponed or put on hold. The child and youth mental health service use diminished by 28% and emergency mental health use by 40%. And from this first period only, it was estimated the accumulated service debt in dental care is 1.4 million visits, which is a huge number actually. And we saw similar effects in other services. Here's one more. Cancer diagnosis diminished by 1,400 cases compared to expected numbers. This is probably not because there is less cancer, on the contrary, and so on and so forth. A couple of things about how really the world was prepared, because we followed very similar preparedness schemes here as in most other Nordic countries and in really OECD countries in general, who most of them had some sort of pandemic plans in place. But what we didn't really foresee completely was several things. For example, that the media went into immediate overdrive mode. And this was much worse than before, partly because the change in media landscape, where we have heavily sort of online services, where if you give an interview 1 minute, it takes 2 minutes and it's all out in the public, and usually both in written and video and oral form. We get lots of experts that came out and from different areas of society, not necessarily health expert at all, but who were convinced that they knew what to do and what should happen. And the big thing was the fear. For us who had worked on pandemic preparedness and maybe infectious disease control in the past, it was a bit of a shock to see how scared people were. For example, I myself, I sat in one debate in TV, and where there were different kinds of people involved in the early stages, and in this there was a politician sitting next to me, and this was the stage where we sort of concluded that the pandemic is here. It will affect Finland. Most people will have the infections sooner or later, and there will be deaths. Although it looks like we will make it. It will not be quite as bad as feared from the beginning. And the politicians were visibly shaken and scared. And this is also the experience when we gave our first sort of predictions to the politicians who were in charge of healthcare, the ministers of health. There were many other things that were there. One surprise was that people and society actually were ready to accept fairly draconian restrictions. This had always, in all pre-planning, been considered impossible, that people would not accept these kinds of restrictions. Global level, rapid closure of borders, mass back migration by citizens living abroad. 60,000 people came from abroad to Finland who live abroad normally, suddenly in a couple of months. And that actually was the biggest influx of virus. There was enormous personal protection gear shortage, other supply and demand shocks. The positive thing was that the vaccine development was so fast, but you have to be honestly say that Western health systems, or better, should the term would be a high-income country health systems, are utterly poorly prepared to a situation like this, even though we thought differently. And the fact that economically a difficult epidemiological situation is clearly worse for the economy than restrictions. You also have to acknowledge that public health is always also politics, because these measures affected everybody, and politics is all about managing joint issues of people and society. So there will inevitably be some collisions of interests. I think I will jump over this because the important question maybe in this context is to discuss if all the control measures in hindsight and the restrictions have been necessary and proportional, as the Finnish law actually would require. If we look at this, the people's fundamental rights were restricted in an unprecedented way. If you look at modern democratic societies, we had restrictions of the right to conduct your livelihood, to normal schooling, to higher education. Actually, universities in Finland were distance working for almost 2 years, almost all of them. This actually had quite substantial effects. Restrictions of meeting among family members, people who had families in care, in various institutional formats or even supportive formats, could not meet their family members, caused a lot of worries to many people. I have here a book by Kristina Hellström, who wrote about her own experiences with her own son, who has some functional challenges, and was in hindsight, when you read what the procedures were in that institutions, they're quite horrible actually. And I'm saying this with the knowledge that the people were not trying to make it horrible for the people in the institutions, but tried their best to navigate around the difficult situation. The problem is that the tools that we actually used were taken quite directly from the toolpack of healthcare professionals. I'm talking about distance and control, different PPE use and testing and all of this. And were they really appropriate for the situation? And did we ask the people what they actually want? Another problem was that many of the measures were continued, at least in Finland, for a very long time, some practically for the entire pandemic. They did weaken people's quality of life substantially, especially in the longer term. And I see very little objective discussion on the proportionality of the restrictions. It's actually quite remarkable that it hasn't been discussed very much in Finland, in the public sphere at least. And you can ask the question in hindsight, especially if the corona infection and the risk it caused so huge to everyone affected, that they really all the measures really were justified. And have some of the measures been continued too long, so that just to protect maybe the institutions for liability issues, that they could be avoided? And is it really ethically okay to protect one population group by restricting the basic rights of other groups? For example, school closures were motivated by the fear that they would, if we would have schools open, spread of the virus would be faster, and therefore elderly people could be at higher risk. This is a very difficult ethical question, and I don't think it has been discussed in a sort of coolly objective way, and I think that would be needed. And I think that's where I would finish now. Thank you.
Thank you very much, Mika. I think this has been really, really interesting to get the bigger picture of where all these decision making is based on so many different points, and I think you're right that discussion is needed about how these measures were justified for the future as well. If we hit a similar crisis, we should be able to use these lessons somehow. Well,
hopefully.
Yes, thanks very much. It's been a packed hour and a half, hour and 40 minutes. And unfortunately, we won't have time for any further discussions right now, but I hope you keep them going by yourselves and with your neighbors and colleagues. And I want to thank all of you for participating and for input and wise words. It's been really interesting to hear about new research and impressive about how solutions were found during these hard times. On behalf of all of us at Nordic Welfare Centre, I want to thank you and wish you all a good rest of the day. Thank you very much.